आइडियल से करना। गुड इवनिंग फ्रेंड्स। आज जो जर्नल क्लब का जो टॉपिक है दैट इज वेरी इंपॉर्टेंट फॉर रेगुलर गायनिकोलॉजिस्ट हु आर प्लानिंग और हु आर डूइंग आईयूआई प्रैक्टिस एंड आईयूआई। उनके लिए जो पेशेंट सिलेक्शन, किसको आईयूआई करना चाहिए, कब करना चाहिए, आईयूआई करते समय हाउ टू प्रिपेयर दिस स्पर्म. If you are not preparing the sperm, then if somebody is preparing the sperm, then they should know what is the actual way of preparation of the sperm, how the preparation of the sperm will help to improve the quality of the sperm, what method of sperm preparation for a specific semen sample, that is very important. If somebody is doing IVF ICSI, then how to prepare sperm for IVF ICSI also. But basically today's talk is, I regularly don't do more IUIs, I do more IVF, but it doesn't mean that I don't do IUI, and I did an IUI and it succeeded this month. How I did it, what was the indication? The patient was having irregular period and I did a stimulation, then I did a monitoring. How I monitored, how I identified the LH surge, how I used the trigger of HCG, how I identified whether she ovulated or not, what type of sperm preparation I did, what type of IUI catheter I used, had I used any luteal support or not. This is the thing which we are going to discuss today, how to select the patient. This is a basic talk for fertility specialists who can go for IUI treatment, and my talk will be also involving, do you need too many expensive instruments for doing sperm preparation? Do you need centrifugation technique or not? Why we do density gradient? How the pellet to be used, and how to isolate good spermatozoa from the pellet. Now the talk is on patient selection, stimulation protocol and monitoring protocol, timing and techniques of insemination. Intrauterine insemination of prepared sperm suspension is a superovulatory cycles, fulfills criteria for classification as an assisted reproduction technique. Again, this is an part of assisted reproduction technique. The modern law says that it is a level 1 clinic, you have to get registered. It is not very difficult to get registered, but better to get registered to do IUIs and better to do sperm preparation by your own. Deliberate selection of a more fertile sperm population, multiple ovulation is induced, and the ovulated oocyte come in contact with the high sperm density in the fallopian tube. This is the basic thing what we do in our IUI method. Cheaper and less invasive compared to other treatment like IVF and ET and GIFT. Today's the book mentions GIFT, gamete intrafallopian transfer, but personally I am not doing gamete intrafallopian transfer nowadays. It's not very much in vogue nowadays. Proper patient selection is very important. This is a very important for IUI patient selection. Why and when, to whom we give this service IUI to the couple. Before going for IUI, how much investigation to be done? It is better to find out the reason behind the infertility. Is there any problem in the uterus, problem in the tube, problem in the sperm? If you feel it is idiopathic, then you can try 3 cycles per IUI as a primary treatment. Application of this method, the whole infertile population should not be done. Who should be suitable candidates for this treatment? This is a very important question. Couple considered for this method should be evaluated thoroughly by clinical history, by physical examination, semen analysis. Again, if there is a very poor sperm count, please don't go for IUI. If there is a severe oligoteratozoospermia, IUI won't work. Postcoital test, whether it is necessary or not, we will come to that point. Day 21 progesterone for ovulation, should we do it or not? And HSG or laparoscopy. These are very important for patient selection. Even simple HSG gives an idea whether you should go for this patient or with this couple IUI or not. Insemination with fresh husband sperm, male factor, subnormal sperm parameter, normal is count more than 20 million per milliliter. Now the WHO is 15 million, 50% or more showing forward progression, 30% or more with normal morphology. Again, this is again a very, very subjective assessment of the semen preparation, semen analysis. Because if you do a high power field assessment, then very well you can understand how much is the count and how much is the progressive motility. But if you want to do an exact sperm count and exact motility and morphology, then you have to stain them, use newer chamber. But the problem with the sperm count is that it changes every day. But looking at the microscope with high power field, what I do gives an idea about whether there is a good sperm count with good motility or not. If there is severely less or no progressive motility visible in slide, or it is just moving sperm, IUI won't work. Again, subnormal sperm parameter, the oligozoospermia, decreased number of sperm is presented to the cervical loss, consequently decreased number is available at the fallopian tube. This is a very common logic. Asthenozoospermia, if it is not moving well, decrease the proportion of the motile sperm and the progression is impaired. Even if they reach the ampulla, they are not able to break egg investment. These are maybe the indication for collecting the sperm and making a consultation and do IUI. Again, a teratozoospermia, abnormal morphology could also interfere with the motility pattern of the sperm. Binding the sperm head to the zona pellucida prior to penetration is impossible. IUI in these cases only useful when there is a proportion of motile sperm and teratozoospermia is not 100%. Again, I am putting this again and again that selecting an IUI patient, selecting a semen specimen for IUI, please see yourself under microscope. If you can see, which you cannot count completely, those sperm, they are moving, the count is good, more than 15 or 20 million. And if it is moving and you cannot track it and goes away from your high power field, then it is a good progressive motility. These are the basic practical point which I take from the sample, because when we do ICSI and nowadays, it doesn't matter how much is the sperm, but for IUI, it matters a lot. IUI patient selection, subnormal sperm parameter, men with subnormal sperm parameter had similar pregnancy rate with those who had normal parameter, provided the prepared sperm suspension contained more than 300,000 motile sperm with at least 10% show rapid progressive progression, forward progression. Even higher pregnancy rate when sperm density exceeded, that is 10 lakhs, 1 million in inseminated sample. These are the references, but these counts are always a relative thing, and this count which is written over here can be counted by Newbar chamber or by Maculus chamber. Pregnancies are still possible when less than 55 lakhs or half million were inseminated, Minimum prepared sperm count required for successful IUI is similar to that of IVF. Again, this point is very important, that after preparing the sperm, the final prepared count should be little bit more. So if it is less than 1 million, chances will be little bit less. Up less than 1 million कैसे देखेंगे? Either you use Mackler's chamber or you use Newbar chamber, and or if you use a high power microscopic field, then you can count them and there will be more progressive motility. Non-liquefied or highly viscous semen rapidly coagulate. Liquefaction start within 5 minutes, complete by 40 to 60 minutes. No liquefaction leads to highly viscous semen. High viscosity impedes the escape of the sperm from the ejaculate. This is a common sense that if there is a high viscosity, there will be. So mechanical methods are employed to tenacious mucus, an aliquot of culture media added to the semen sample, and repeated aspiration expulsion through the 19-gauge hypodermic needle. Again, be careful about putting too much pressure into the needle, to the syringe, because it might damage the sperm also. So there should be a gentle repeated aspiration, and it may help to liquefy the semen. When there is a hypospermia, when the volume of the semen is less, congenital absence of seminal vesicle, blockage of the ejaculatory duct, loss of volume, small volume of the ejaculate may be deposited well away from the cervix, and sperm does not come in contact with the external os. Again, small volume of the ejaculate is inadequate to raise the pH of the vaginal acidity. Then sometimes IUI helps, as the sperm gets concentrated and the prepared sperms are placed inside the uterine cavity. So these are few indication, but when there is a problem with the seminal vesicle, we usually don't get too much sperm while doing aspiration from the epididymis. And personally, nowadays it is being used for ICSI because prepared sperms will be very less. If there is again, it is indicated for impotence or ejaculatory dysfunction. If you can treat them very well, but lot of which are not possible to get treated, these are the indication you can use these as a for IUI. The method of obtaining semen irremediable impotence. Again, there are many methods for erection. You can surgically aspirate. Penile vibrator can be used, and rectal electrostimulation can be used. Again, these are specialized things which we need for rectal electrostimulation and all. But if you can get 2-3 sample and freeze them, then you can do IUI in a subsequent cycle. For retrograde demonstration of sperm in the detection of fructose in the urine following an orgasm, goal of treatment is, if you want to get sperm from the retrograde ejaculation from the urine, better to reduce the acidity of the urine by alkalizing the urine and receive the sperm as soon as possible after orgasm. Again, the next factor is cervical factor. These things which, when we use clomiphene citrate and lot of drugs which may create abnormal cervical mucus. So how the cervical mucus helps? It is produced mainly from endocervical cells. More than 90% is water. And estradiol stimulates the production of copious watery mucus, and the volume reaches 500 microliter per day. Progesterone inhibits production. Fertility related function of the cervix and mucus. The mucus helps to the survival of the sperm, and it helps to entry and protect the sperm from vaginal acidity if we get good cervical mucus. And nutrition of the sperm is also noted. Fertility related function of the cervix and mucus. The selection of the sperm based on motility characters, sperm reservoir function, and initiation of capacitation. Nature makes the cervix to hold the sperm at the time when the lady is ovulating. Just before the ovulation, there will be rise in estrogen, and rise in estrogen will create copious amount of mucus, which are rich in sodium chloride. And it is helping to neutralize the vaginal acidity. So nature is creating a substance which makes the channelization of the cervical mucus, and sperm can travel through that. If cervix mucus is not good, then there will be difficulty in travel of the sperm into the uterine cavity. So cervical mucus abnormality is another very important indication. We can test this by postcoital test, usually not done nowadays. In vitro sperm cervical mucus contact test. These are all textbook things, but not very much used nowadays. And evaluation of the mid-cycle cervical mucus is not commonly carried out. So the postcoital test clinical value is controversial, interpretation is difficult, negative test may be genuine or lack of coitus. So it is not very much used nowadays. Causes of infertility will be by mucus, inspissated cervical mucus, and deficiency or absence of the cervical mucus. There may be some tumor in the endocervix, severe cervical stenosis, and chronic endocervicitis. These may be the cause of cervical factor of infertility. IUI in patient with cervical factor infertility is generally effective as it bypasses the cervical block. Pregnancy rate between 50 to 70%. It is written in these references, but definitely the chances of getting pregnancy through IUI there are multiple factors involved. So the overall pregnancy rate per attempt is 11 to 12%. Next indication is ovulatory disorder. Everything is okay, but the lady is not releasing eggs regularly. Then again, there will be infertility. Can we induce the ovary and get a follicle, get an ovulation, and then at that time, there might be a good, if timed intercourse is not functioning well, then we can do IUI. So ovulation disorder is responsible for 30 to 40%. If ovulation induction and the timed sexual intercourse is not successful, pregnancy rate might be 30% per cycle, because the chances the patient which I did having some problem because she was little bit overweight and the ovulation, periods got delayed of more than 35 days. There might be some problem. I induced her and tracked the follicle and she conceived. Again, endometriosis is one of the very important reason for infertility. So mild minimal disease may be related to with the infertility, and there is a report in literature that this endometriosis IUI may help. Again, recurrent early pregnancy failure may be caused by chemical agents released by endometriosis. IUI is an option when the mild disease and ovaries are free of disease. Pregnancy rate might be 11.5%. Poor follicle response to IVF superovulation protocol. Here the action is oocyte pickup may be useless and dangerous when the cycle may be turned into IUI cycle. Very rarely done nowadays in my center, but better that IUI can be converted into IVF if there is a hyperstimulation, which I will come to. This is again not a very valid point to do IUI because immunological infertility is not well established reason for infertility. There is a controversy. So I am not going into that immunological infertility part. Again, anti-sperm antibody is not nowadays not done. And if it is there, then ICSI is the best option. IUI is helpful in cases, especially those where cervical anti-sperm antibody. We are not assessing nowadays anti-sperm antibody either in the maternal blood or in paternal blood or in the cervical mucus. So there are chances that anti-sperm antibody can be removed by washing the sperm. IUI is worth trying, so-called immunological infertility. Unexplained infertility is very important, and how to say some infertility is unexplained, again a very questionable thing. Your explanation should go up to the limit that you can do in your center, how much you can go to find out the reason. What I find that all mostly in idiopathic infertility, unexplained infertility, there is a lack of fertilization and the problem in the tube. But if HSG shows good quality tubes and patient is healthy, then standard investigation fails to reveal a cause of infertility. Age and prolonged infertility creates a situation of stress, then IVF is ideal. Again, it happens with age and stress which create difficulty in ovulation. IVF pregnancy rate can be up to 27% of treatment independent pregnancies, 1.1%. These are reports which may help in a lady who are under stress. Maybe normal, everything is okay, but she is not conceiving. Again, this is another logic that if husband is absent, then we freeze the sperm, and anti-neoplastic treatment, especially if test is to be eradicated, and vasectomy before. So frozen husband sperm can be used. Poor with poor semen parameter, poor quality sperm sample can be cryopreserved and then pooled at the time of IUI. If ICSI is not available, then this can be done. You can freeze the semen sample, then pool them and get at least 1 million, more than 1 million motile sperm count in the final prepared semen. But the fact is, thought samples are also poor. Alternate is repeat semen analysis every 2 to 4 weeks for 8 months. Episodic improvement may be noticed. If you don't get too much time, if AMH is reducing, then don't wait, go for IVF ICSI. Better quality samples are cryopreserved. These samples are then pooled and pregnancy rate may be 27% reported by Avulgar et al. So indications are isospermia with primary testicular failure, severe abnormal parameter, persistent failure of IVF ICSI, some hereditary disease, rhesus isoimmunization. With these cases, personally, even with the primary testicular failure, I try not to use donor sperm, and we do andrological evaluation, and even micro TC or TC can be done, testicular sperm aspiration. Even few sperm can help to get the baby from their own biological material. Severely abnormal sperm parameter, persistent failure. So these are the conditions you may think about for donor sperm, and the contraindication is very, very important, that where you should not do IUI. If you see pathology in tube, in HSG or laparoscopy, there is genital tract infection, severe semen abnormality, genetic abnormality in husband. Again, this genetic abnormality can be identified pre-implantation genetic test, find out the genetic test, whether we can get a healthy baby or not. Unexplained genital tract bleeding, again think about whether there is any pathology or not. Pelvic mass and older women. Older women means that is, if AMH is too low, better not to do IUI. Multiple infertility etiologies, pelvic surgery, pregnancy contraindicated, multiple failures of IUI. Most pregnancies achieved in the first 3 or 4 cycles. If not, then patients should go for another modality of treatment. This is very, very important. What happens, patients sometimes go for IUI for one doctor, then again 2-3 IUI for this another fertility center. Then total number of IUI becomes too much, and there is a frustration for the patient that nothing is happening. So IUI should be better, that 3 or 4 cycles. If you are confident enough that IUI is indicated in this patient, then this can be tried. But again, I tell you about our experience that IUI is also a very stressful affair for the doctor and for the patient. If it fails, then she has to come again for ovulation, again for follicular monitoring, again for IUI. So better to understand the cause of infertility and treat it specifically. The technique is, it confirms the motile sperm into uterine cavity. Better specimen with good motility remains the cervical crypts and release episode. Poor samples should be inseminated more frequently or closer to the time of ovulation. It is better to do IUI nearer to the ovulation. If you put HCG as a trigger, it happens after 42 hours that ovulation may take place. But it doesn't mean that if it happens in the 42 hours comes late night and you have to do immediately, it is better to choose the time for HCG and then use the time for IUI with convenience of both patient and the doctor. Again, the technique, I'm going to show you how the preparation to be done, and these are very important things that seminal plasma should be removed as early as possible from the sperm. Nature does seminal plasma by two methods, that is from seminal vesicle and mostly from seminal vesicle, and there are two parts, that is ejaculation and emission. So the epididymal sperm are present and it is thrown by expulsion, and the seminal vesicle fluid is added with the sperm. So there are multiple things which are coming with the semen along with the sperm. First, to neutralize the vaginal pH, give the support to the sperm in vitro in the vagina, but it carries lot of cells which create reactive oxygen species. If you keep seminal plasma with the sperm, there will be damage to the sperm. There will be damage to the sperm head, more development, more release of the reactive oxygen species, and there will be less chances of fertilization. Sample should be maintained at 37 degree. If it is not specifically 37 degree, at least more than 25 to 30 degree. Sample can be held in fist if no incubator. Very common logic. Sterile powder-free gloves should be used when preparing vulva. Should be cleaned with warm saline. No Savlon or betadine or toxic to the sperm. Now again, insemination catheter, there are multiple nowadays companies, they come with the IUI catheter. And what I feel, those catheters which are being used are very tough catheters. Sometimes the tip doesn't go inside the internal os. So if it doesn't go the internal os, you can't hold the cervix, because moment you hold with the valcellum, there will be release of prostaglandin and there will be uterine contraction. And patient will have pain also and discomfort also. What to be done with these patients with this insemination? What I do, I try a simple IUI catheter, which is insular type of catheter, which is small tip, and with the syringe, if it goes inside the cervix, then better to go with the internal os. If it crosses the internal os easily, no problem. But if it abuts the internal os and doesn't go inside of the uterine cavity, nowadays I use an embryo transfer catheter, which is very soft and the inner one is very thin. And if you have better facility, then you can use ultrasound for the guidance of the catheter, so you can get confirmed that your inner catheter is inside the uterine cavity. When it goes inside the uterine cavity, before that, the semen, the prepared sample contains, the catheter contains some dead space, that is air. You should fill that air space before entering into the uterine cavity, so that only prepared semen sample is deposited into the uterus. If you put too much air inside, then this air will replace or displace the sperm sample and it will come out. So these things are very simple things, but has to be taken care of. Dead space in the catheter should be kept in mind. Best way, I think it is not correct. Pass the uterine cavity for a distance, okay, from outside it is 6 centimeters. The patient lies supine for about 5 to 10 minutes. Rising the patient's hip may prevent the back. Principle is use a large volume of the sperm suspension. Now this is IUI technique, tubal perfusion. I don't do, but it has been written in the previous books. So the more amount of sperm is used so that it goes in directly into the fallopian tube, problem of backflow can be overcome by blocking the cervical canal. Again, this is I used very early fallopian sperm transfer system by Fanchin. Cervix is blocked by vacuum device and a con tip. Sperm suspension is pushed over 2 minutes slowly. So these are the method by IUI technique tubal perfusion. I used early as with a simple sterile Foley's catheter, and bulb can be placed in uterine cavity and pulled down to seal the cervical canal. Bulb can be placed in the cervical canal itself. Again, there is a problem if you inflate this bulb too much, then there will be expansion of the either uterine wall or uterine cavity or expansion of the cervical canal. That will create pain. So there should not be any pain. 4 ml of sperm suspension can be done, and this is a method of tubal perfusion by simple Foley's catheter. Now, the main thing which I feel is how to prepare this sperm sample. Kuch questions?
Yes, sir.
If there are
Three questions are there. What tests are required prior to ensure that IUI is the preferred treatment options?
Again, the same question is that there are at least 3 tests I always say. One is find out fertility of the patient. Whenever we do IUI, patient comes, there is a husband and wife. This is wife and this is husband. For wife, there should be a fertility test for AMH. Very important to know whether she is fit for IUI or should go for IVF. Suppose it is 1.2 or less than 1 nanogram, then better to go for IVF. But if it is 3.2, if more, then we can go for IUI. Second, whether she had undergone HSG or not. That is, the tubes are open or not. Very important. Now see don't go with the report which is written on the printed paper. Go for HSG, what you see on the X-ray. If the tube is of like this, of same diameter throughout, this is called lead pipe rigidity. Even though it is patent, it will not work. If there is a dilatation of tube like this, then there is salpingitis ischemica nodosa. It will not work. Again, if there is a dilatation of the terminal part of the cervix, this tube, and there is a spillage, this will not work. So HSG is very important. If laparoscopy has been done and had been seen about this, the tube is open, but the quality of the tubal inside mucosa is visible by HSG only. So HSG is very important. So second test is AMH and second test is HSG for the patient, and if possible, get a serum progesterone done in the previous cycle. If it is more than 5 or better, it is 10 nanogram per ml on day 21 or 7-day post, or better that the next period when it comes expected less than 7 days. So the thing is, she is ovulating and she is having good tube and having good ovarian reserve. For the husband, there should be a semen analysis, preferably by a good pathologist or by yourself, so that you can see under microscope with high power field. You cannot count those sperm and they are moving around. So you can definitely make that it's more than 15 million. And if it is moving, then there is a progressive sperm. Then these can be used for IUI. If you want to have better count and all, then ask your pathologist or fertility specialist can use macular chamber or Newbar chamber.
One more question. Is it safe to have intercourse before and after IUI?
It is always better that you should have. Basically, IUI, what we are doing, we allow this egg to come out and it goes inside the tube. And we are putting the sperm inside the uterine cavity. So it goes here and or here and it gets fertilized. Now, whenever there is an act of intercourse, the semen doesn't flow like a water flow. It comes out as spurts. So the first spurt which comes out from the penis during ejaculation, it is exposed to the cervix with good amount of mucus. Cervix catches those spurt and this spurt contains maximum number of motile sperm. So there is a collection of sperm inside the uterine, this cervical area, and it acts as a reservoir and it continuously releases sperm inside the uterine cavity. So it is better to have intercourse. If you have a good semen analysis, then you can have after insemination. It will help you to get, because natural intercourse is also a natural intrauterine insemination.
One last question, क्या IUI में भी ट्विंस प्रेगनेंसी के चांसेस होते हैं?
Very important question, very important. क्या IUI में भी ट्विन के प्रेगनेंसी के चांसेस होते हैं? सबसे बड़ी प्रॉब्लम IUI के साथ ये होती है कि जब भी हम IUI करते हैं या जो भी करवाते हैं, जो भी डॉक्टर करते हैं, आप देखोगे कि डे, ये पीरियड हो गया, डे 3 से 5 दिन की दवाई देते हैं, तो 3, 4, 5, 6, 7, ये डे 7 तक चलता है। ये इसलिए देते हैं कि नॉर्मली जो एक एग बनता है, एक ही एग का डेवलपमेंट होता है एंड इट कम्स आउट. सो नेचर रिलीजेस 1 egg एवरी मंथ. नाउ इफ यू गिव दिस ड्रग, इसमें बहुत सारे ऐसे फॉलिकल रहते हैं जो कि आगे बढ़ते हैं पर छूट जाते हैं बिकॉज देयर इज सिलेक्शन ऑफ वन. नाउ मोमेंट यू गिव एनी ड्रग, ये जो छूटने वाले जो फॉलिकल हैं दे ऑल्सो ग्रो, ये भी बढ़ते हैं. अब सपोज ये 4 या 5 बढ़ गए और आगे बढ़ के इसमें से सब में से ये निकल आया, तो ऐसा भी होता है कि यदि आपने इसका ध्यान नहीं दिया अल्ट्रासाउंड में कि कितने फॉलिकल कितने साइज के बने और आपने इसमें ट्रिगर लगा दिया, देन देयर विल बी रिलीज ऑफ एग फ्रॉम मल्टीपल फॉलिकल एंड एवरीथिंग इज गोइंग इनसाइड द फैलोपियन ट्यूब. फैलोपियन ट्यूब के भीतर ही सब जा रहे हैं. अब यहाँ से आपने स्पर्म छोड़ा या उसके बाद नेचुरल इंटरकोर्स हुआ, then these eggs can get fertilized. तो ट्विंस क्या ट्रिपलेट क्वाड्रुपलेट भी हो जाते हैं यदि अनकंट्रोल. तो आईयूआई में एक सबसे बड़ी प्रॉब्लम ये रहती है कि आप जो ओव्यूलेशन करा रहे हो उस ओव्यूलेशन का मेथड क्या हो. इस ओव्यूलेशन के मेथड में आप आईवीएफ में तो बहुत इजी है कि आप आईवीएफ में इसका खूब सारे एग्स बनेंगे तो आप उनको आप निकाल ले रहे हैं, एक जगह पर कलेक्ट कर ले रहे हैं. सो देयर विल बी, यू कैन कंट्रोल दिस. यहाँ एम्ब्रियो बनेंगे तो यू कैन कंट्रोल द ट्रांसफर ऑफ एम्ब्रियो, 1 करो या 2 करो, देन यू कैन कंट्रोल इट. बट इफ यू डू सेम थिंग, सेम स्टिमुलेशन विथ आईयूआई, तब आप ये यू आर नॉट रिमूविंग दीज, then it may come out and go. So there will be chance of multiple pregnancy. This is very dangerous affair sometimes. तो हम कौन सा स्टिमुलेशन यूज करें? तो हमें वैसा स्टिमुलेशन यूज करना चाहिए जिसमें कि हम फॉलिकल में जो ओवरी है उसके जो सिलेक्शन मेथड है उसमें जो उसके रेस्टिंग फॉलिकल्स हैं उसमें हम मोनोफॉलिकुलर 1 या 2 फॉलिकल का ही डेवलपमेंट हो, ऐसे यूज में हम अधिकतर लेट्रोजोल यूज करते हैं. Letrozole gives a help to develop monofollicular development in जहाँ पर ओवुलेशन अच्छा नहीं हो रहा है। पर जहाँ अच्छा ओवुलेशन हो रहा है आप नेचुरल साइकिल में भी जा सकते हो, और यू कैन स्टिमुलेट विथ लेट्रोजोल, देयर विल बी लेस नंबर ऑफ डोमिनेंट फॉलिकल्स, और मल्टीपल प्रेगनेंसी का चांस विल बी रिड्यूस्ड। बट इफ दिस हैपन्स कि इसमें भी बहुत सारा बन गया, then don't take chance of triggering them and then get a multiple pregnancy. Pregnancy तो होगी, but there will be chances of getting multiple pregnancy.
सर एक क्वेश्चन जो लास्ट आपने आईयूआई के जो अभी 3 दिन पहले पॉजिटिव आया है, उसमें बीच में आपने कुछ इंजेक्शंस भी यूज किए थे, एचएमजी इंजेक्शंस, बीच में कुछ एलएस टेस्ट कराया था, तो वो किसे करवाया था?
Again, in this case, I used a very strict monitoring protocol for this patient. This patient is little bit overweight, और उसका जो AFC था, interfollicle count was good. That's in, I think, 9 to 10 per ovary. So I used letrozole, and this letrozole was given for 5 days, and followed by I give HMG 75 for 3 days. Here I didn't use एंटागोनिस्ट, क्योंकि एंटागोनिस्ट जो ही आप यूज करोगे आप पिट्यूटरी को ब्लॉक करोगे, देन यू हैव टू गिव लिटिल बिट हायर अमाउंट ऑफ गोनाड्रोपिन, बिकॉज एकदम से सब बंद होगा। बट विथ एचएमजी देयर विल बी मोर नंबर ऑफ फॉलिकल. आई मॉनिटर्ड दैट बिकॉज लेट्रोजोल वाज यूज्ड, सो देयर वाज ओनली 2 फॉलिकल. Now this follicle is getting bigger and bigger. There is a, because हमने antagonist use नहीं किया, so there is a chance of premature LH surge. तो बंद कर. There will be premature LH surge. ये बहुत important है. यदि at the time of development of the follicle there is a rise of estrogen, with this estrogen it reaches up to a threshold of 250 picogram per ml. This LH जो कि नीचे बैठा हुआ है, ये सडनली पीक मारता है. अब पता चला कि इस समय जब हमारा 2 फॉलिकल बन रहा था, so this normally this estrogen goes here, इतना टाइम लेके, पर यहां पर जब हमने फॉलिकल ज्यादा बनाया 2, तो ईस्ट्रोजन का वॉल्यूम भी बढ़ गया, तो इट विल रीच अर्ली. इफ इट इज रीचेस अर्ली, सपोज जो यहां पर हम, यहां पीरियड है, ये नॉर्मली 11th डे या 12th डे में जाता है इतना ईस्ट्राडियोल, ये पहुंच गया 10th डे में, देन देयर विल बी फॉलिकल की ग्रोथ तो उतनी नहीं हुई, बट ईस्ट्रोजन बढ़ गया. हम उसका अल्ट्रासाउंड कर रहे हैं. इफ अल्ट्रासाउंड में हमें 16 मिलीमीटर मिला तो आई विल डू HCG ट्रिगरिंग व्हेन इट गोज अप टू 19 मिलीमीटर. नाउ फ्रॉम 16 to 19 मिलीमीटर इट इज प्रोड्यूसिंग ईस्ट्राडियोल आल्सो. ईस्ट्रोजन भी बना रहा है, ईस्ट्राडियोल भी बना रहा है. दिस ईस्ट्राडियोल फ्रॉम द 2 फॉलिकल इट इज राइजिंग. नाउ इफ आई allow it to go for 16 to 19, there will be rise in estrogen and there will be premature LH surge. अब हमको LH surge यदि समझ में नहीं आया और फिर हम 19 में उसका HCG दे रहे हैं, so there is already LH surge occurred and there will be either release of egg, और इस ट्रिगर के बाद जो एग रिलीज होगा वो प्रीमैच्योरली मैच्योर एग होगा. This will not create pregnancy. So these all things will be in vain. मैंने क्या किया, 16 तारीख को I could have used urine LH कार्ड, जो मैं करता हूं काफी, इसमें मैंने यूज नहीं किया. What I did serum LH on 11th day with P4. Patient was paying, so I did it. The P4 was less than 1, that is point, I think 0.76 nanogram per ml, and LH was 5.6. And the quality of the follicle I see on the ultrasound, and it was 17 to 18 millimeter. I found that LH is less, endometrium is good, and LH is 5.6. So I am sure that there is no premature LH surge. LH surge तब होगा जब more than 10 मिली इंटरनेशनल यूनिट पर ml हो जाए. यदि इसके ये आ चुका और आप उसके बाद यदि HCG का ट्रिगर देंगे तो इस HCG का कोई यूज नहीं है और एग्स भी खराब निकलेंगे. So what I did, I found this in the same day. It was 18 millimeter. I gave an HCG trigger. When given, शाम को 8 बजे, कितने बजे?
Yes,
शाम को 8 बजे, 8 p.m. From 8 p.m. I get 8 p.m. Then next 8 p.m. 24 hours. Then next 8 a.m. 12 hours, total 36 hours. And patient comes to me at 12 noon to 1. And we did IUI with embryo transfer catheter. मैं आजकल embryo transfer catheter ही यूज करता हूँ because it is nowadays little bit Indian make, a little bit cheaper. So इसका जो catheter का जो technique है, that is it contains a very soft internal catheter, and we release it without holding the uterus, just with the help of a Sims speculum. Because HCG, so I give dihydrogeston, Dufaston 10 mg BD for 15 days. And after doing this transfer, on 15th day, I did beta HCG. That is 124. So she gets a pregnancy. So basic thing is, whenever you do IUI, if you use ovulation induction, so mind it, very important thing is that it should not be multi-ovulatory. The ovary should not have multiple large follicles. Don't do IUI. Convert it into IVF if it is possible, if you can monitor it or if you can convert it. It is better to do 1 or 2 larger follicle and go for IUI. Second, whenever you wait for this size to improve after 16 millimeter, think about premature LH surge. Because if this happens, then all eggs will be in a bad situation, bad health. So pregnancy rate will be less. How to understand and how to identify premature LH surge? Either you do everyday LH. LH is specifically serum test, and I find it very useful. It cost, how much it costs? 400.
400 rupees.
400 rupees each day, at least once or twice, depending upon the size of the follicle. But you are confident that there is no LH surge. If you get LH more than 10, one day it is suppose 4, and next day you do LH, it is more than 10. Then this can be used with HCG trigger on the same day. Will give an additional boost to this LH surge, and you can get a good follicle and good pregnancy rate. But if you don't do this, and if it is already 10, and if you not did it properly or early, and you put HCG, it is already 10 here, so you are quite late. You cannot put HCG in a smaller follicle also, so you can manage it by doing LH because we are doing LH in our lab, so it gives within 2 hours we get the result. But for a common where the problem is that LH is not being done, or you have to send the sample outside and getting result after 2-3 days, use LH card. LH card is just like an urine pregnancy test. आप यहाँ पर यूरिन तो कब करना चाहिए, जो लेटेस्ट स्पिरॉफ में जो लिखा हुआ है, दैट इज हम कोशिश ये करते थे कि मॉर्निंग सैंपल का यूरिन इस्तेमाल करने का, बट दे हैव रिटन दैट इट इज बिटवीन 11 to 2 noon the LH surge happens. So better to do at 4 to 5 p.m. urine. Ask the lady not to take too much water before that, 2 to 3 hours before doing this, because if you dilute it, then there will be false result. So it gives a better result. Put this urine here, and there is a test line and there is a control line. If control line is only there, no test line, it is negative. So you can continue with the stimulation or with the ultrasound. If it is one day, it comes with test line also. It is the day of LH surge. Next day, you can give IUI. You can do IUI. If you are not using HCG, then you can do this method. If you want to do HCG trigger, then make it that on the day of HCG, continuously there is only test line, no control line, and follicle has reached to level of 17 to 19 millimeter. You can definitely put a HCG trigger artificially LH surge, because there is no LH surge, so it will give you a better result. Thank you very much for patient listening. I think a lot of things can be cleared, and if you have any question, I will put with the comment section, I will put those questions in the, but the monitoring of the IUI is very important. If you are putting some effort to do IUI and patient is coming to you for IUI, if you want to use how to reduce the time doesn't permit to what are the techniques of sperm preparation. There are multiple methods of sperm preparation, which is a technical method. I can come it with the next topic with sperm preparation technique, how to use in a virally infected husband with hepatitis B, with HIV and other bloodborne viruses, hepatitis C. And should we do centrifugation of the sperm or not? If you don't use centrifugation, what are the methods? Then what is, because time doesn't permit, then I will come with the next talk with microfluidic technique, how to get good sperm without doing centrifugation, what is density gradient technique. I will come with next journal club with those techniques. Thank you very much for patient listening.